Hi, this video is about getting back on track after bariatric surgery. This is for folks who had their bariatric operation some years ago, probably did great with their weight loss for a few years, but now things are getting out of control and they're starting to gain weight again. The first thing I want to let you know is that you are not alone. We understand that this obesity condition is a lifetime metabolic disease, and whereas it's unfortunate to gain weight back over time, it's not really a surprise, and we, your bariatric team, ought to approach this from a medical and a biological and a hormonal perspective. Years ago, we bariatric surgeons would claim that bariatric surgery would more or less cure the obesity condition. We understand now that that was too big of a claim. What medical knowledge is showing us these days is that bariatric surgery has a strong positive impact on the obesity condition and the hormone imbalance, and that long-term medical maintenance is necessary, and that additional interventions might be necessary to keep the metabolic disease under control. In other words, the surgery is a major step in the overall process of the lifetime management of this obesity condition. So often, patients who come to see us to get their weight and metabolism back under control feel ashamed. They feel that they've failed themselves or failed their surgeon in some way. And I understand this because society has been telling you for years that your weight control is all about your personal responsibility, your decision making, your personal choice. Medical science is teaching us differently. Medical science is teaching us that this is a biological, hormonal issue. It's maybe 70% here and 30% here. So I hope instead we can have a constructive conversation about the things that we can actually do on a practical level, medical level, to help get your metabolism back into balance and help get your weight under control. I hope I can let you shed some of the guilt that you may have been feeling. My name is John Pilcher. I'm a bariatric surgeon in San Antonio, and I've been doing bariatric surgery since 1995. And I've seen a lot of patients come back to the clinic after years of gap in follow-up with some weight regain, some metabolic imbalance, and the most common question is, can you fix my surgery? That makes sense to me because most patients have had the experience of the surgery working fantastically well for a few years, and then the impact or the potency of the surgery tends to fade over time, almost as if the surgery's gotten kind of stretched out. And so I want to give you a disclosure about this video. We are going to talk about the concept of revision surgery, but this video is not primarily about revision surgery for bariatric patients. This video is going to be primarily about all the other things that can be done from a metabolic and a biological perspective to work with the surgery to get the weight and the metabolism back into good shape. I opened the video by saying that we are going to discuss the process for getting back on track, so it's useful to talk about what it means to be off track. And yes, off track usually means that there is some weight regain, but when I talk to patients, what I also get as a key priority or a key worry for them is that they feel out of control. Early after the surgery, they felt like they really understood how to eat and how to exercise. They felt natural with the right type of food and the right type of exercise. But over time, that's become more difficult and they feel themselves attached to some of the wrong foods. They know these are the wrong foods, but they have cravings and urges that don't make sense and that they know on a level are counterproductive. So we as the bariatric team are going to help focus on getting a metabolism back under control to get the sense of energy back, to get the sense of hunger back under control, and then typically the weight loss will follow in a natural way after the metabolism is corrected. When you go back to re-engage with your bariatric team in long-term care, I think it's reasonable to expect two parts in the process. First of all, the bariatric team is going to evaluate your current medical situation, looking at several factors I'm going to discuss in detail as we go along. And then they're going to make a plan for optimizing each of those factors so that we can work to keep your metabolism under control. I like to organize this process of evaluation and intervention by focusing on the concept of a healthy metabolism. And we can identify numerous factors that point towards a healthy metabolism. It's nice to have a system, and I like to use the system or the image visualization of thinking about a temple of healthy metabolism. So there's a foundational set of factors that point towards a healthy metabolism, and the focus of this video is going to be the 5 pillars that support the roof or the temple of this healthy metabolism. In this concept of healthy metabolism and the temple of metabolic health, the 5 pillars are healthy eating, the right food plan, sufficient vitamins, surgery, the right type of exercise and regular exercise, and then potentially pharmacology or medications to help boost the effects of surgery. Now, I've placed surgery as the central pillar here, a little bit selfish maybe, but that's because I'm a bariatric surgeon and because this video is mainly for people who have had bariatric surgery and are working to get back on track and to have their surgery work with these other pillars to support the temple of metabolic health. I've also started with the pillar of surgery as the central pillar. It's actually going to be the first pillar that we talk about because it's hard to get to the other pillars unless we know that surgery is doing all that it can do. So we are going to jump first and talk about surgery evaluation as the first step of getting back on track. One more thing to take care of before we get to discussing the surgery pillar and the other 5 pillars of healthy metabolism, and that's going to be the foundational factors that support this temple. And I don't have a lot to say about these foundational factors in the talk today, but I'm going to mention them briefly here, and I think they're important to have taken care of as I said, a foundation for moving forward with the rest of the discussion. The first thing is that you need to be engaged. Engagement just means that you're paying attention to this, that the weight control and the healthy metabolism are a priority in your life at this time. Weight control, metabolism, health doesn't have to be the #1 priority in your life because there are other valid priorities like family and work, but really weight control, metabolic health should be in the top 3 if you're going to put the energy and time into this that's going to give you lasting success. The second foundational piece above engagement, which is the time and energy aspect, is the resources. Resources means a few things. It means the family support. It means having the time available to come to appointments. It means the financial resources, insurance coverage, and those kinds of things that'll make it possible for you to engage intensively as is going to be necessary to get the team to change these 5 factors that are going to point to your healthy metabolism. The third foundational factor is going to be what I call psychology. Psychology just means in this case that you are in control of yourself. And because it's going to be necessary for you to change habits and do things to work with your surgery to get the most out of it. I said just a minute ago that this is a 70%, 30% proposition, but of course to get the most out of the 70%, to get the most out of the biological change, you are going to need to work with the surgery, and so many of us have some sabotage habits that may need to be figured out. Now, the fact that you're watching this video right now and applying this time means that you probably do have the engagement and the resources and the psychology to be able to work with this. But if not, please be aware that most bariatric teams nationwide have connections with health professionals and other support teams that can help you get the foundational pieces on track so that the 5 pillars can do all the work that they potentially can do. Now, the fact that you're still with me at this point in the video means that you probably understand that some refresher education is worthwhile, but still it's got to be in the back of your mind about, well, I've heard this before. I've already learned so much about my metabolic health. Why do I need another video? Why do I need more education? There's a couple things going on here. I would say, first of all, medical knowledge does continue to improve and evolve. We, as bariatric team members, are teaching different concepts and different facts than we did 5 or 10 or 15 years ago. In fact, this video was recorded in 2019, and if you're watching this 2024 or later, you should take what I say with a grain of salt because we may have learned more in the intervening time interval. Second thing is that there's so much information out there, and some of this information is actually driven by marketing. For example, we as bariatric surgeons didn't understand before how much artificial sweeteners can be deleterious or damaging from the standpoint of metabolic health. These are marketed as being healthy alternatives to sugar. We're learning that they're not actually that healthy, and I'll say more about that in a few minutes. But just given that there's so much information out there, if this is not your full-time job, like it is my full-time job, it's not reasonable to think that you're going to be able to separate the wheat from the chaff in terms of all the information out there and all the conflicting information. So we're going to try to give you what the best understanding right now is of how to get to the best metabolic health. And just as surgery is usually the first topic of conversation when a patient comes back after years of lacking follow-up, we're going to go into surgery and the discussion of evaluating the surgery as the first key subject in our 5 pillars of the obesity condition. So surgery again being the central pillar here. We're going to talk about this before we talk about the food plan, the vitamins, the exercise, and the pharmacology. Now, overall in this video, I'm going to take a very cautious approach to the idea of revision surgery and talk about the importance of the other pillars in helping surgery work well, but people who have had a band previously need a special discussion. I've already put a video out there that talks about why bands tend to fail in a very high percentage of cases, so I'm not going to discuss that in great detail here. But if you have had a band operation, my opinion is that the band should come out, and most people who have a band are candidates with band removal. They are candidates for transition to a more definitive or more effective operation, such as the gastric sleeve or the gastric bypass. As we think about people who have already had a sleeve or a gastric bypass, that's where I'm going to talk about the evaluation, but I'm a bit more cautious about jumping into additional surgery or revision surgery. Most surgeons and most bariatric teams check the anatomy of the existing surgery using endoscopy. Endoscopy is done under light anesthesia, and this is where the physician will use a flexible scope with a light and a TV camera to go down and actually look inside the stomach and to see the surgery from the inside. And for bands, this is a great option because it's very important to make sure that the band has not eroded and to see where it sits on the stomach. For a sleeve or a gastric bypass or other bariatric operations, the scope can be very useful, and it's the most common approach. For me personally, I like an X-ray test called the upper GI series. In the upper GI series, the patient will drink some thick, lovely, chalky fluid, and they will swallow that fluid. X-ray will track it, and the radiologist will take pictures of our surgical anatomy from multiple different angles. I like this a little bit better than endoscopy alone because I can use the X-ray pictures to map out my surgical plan or to discuss it with the patient about why perhaps there doesn't need to be a surgical plan. But either one of these is going to be useful, sometimes in combination. CT scan is the other imaging modality, the other test that's often used to check bariatric surgery anatomy. That's more applied for urgent situations such as pain or nausea or vomiting or bleeding, and it's not quite as useful in the scenario of my metabolism is out of balance and I've got weight regain. So most often your bariatric team is going to be talking to you about endoscopy or the upper GI X-ray. Now, interestingly, the results of these tests evaluating your bariatric operation are most often you have normal surgical anatomy. In other words, things aren't broken, they're not stretched out, they actually look okay. And the patient response to this finding, this normal finding, is what the heck? Because I'm the patient and I can suddenly eat all this food, and it worked great for me at first, and now I'm able to eat all this and my weight's coming back, so it must be a surgical problem. And this is a tricky conversation, but it's an important one to have. What usually happens is that over the years after the surgery, the stomach naturally returns to its physiologic stretchiness. And I need to teach a little bit about what's involved here. So in normal stomach anatomy, this is pre-surgery, the stomach tissue is naturally stretched like a kid's balloon. And so it can expand up to being 3 or 4 times its normal size and then shrink back down to a normal smaller size with no damage whatsoever. This is how we can go back for thirds at Thanksgiving. Now, when the surgery is done, and I'm mainly talking about sleeve and gastric bypass, there's a natural swelling or stiffness that happens in that stomach tissue so that it loses its natural stretchiness and it becomes very stiff from the natural swelling that happens. And so it, for 6 months or even a year after the surgery, it is physically quite restrictive. But then gradually over time, it regains its natural stretchiness, and so the food capacity will increase back, not all the way to where it was originally, but back to a higher capacity, an increased food capacity. The other thing that happens with both the sleeve and the gastric bypass, and this is another process that takes months and months to happen, is that the stomach becomes more effective at emptying out even as you eat. And so people who initially start off with a great deal of restriction after their operation will gradually develop an increased food capacity and be able to eat almost like normal people. And for better or worse, this is actually a natural process. And for many, many patients, this process of increased capacity doesn't lead to weight regain because the operations are not mainly restrictive operations. Now, I need to explain this also. The concept is that you look at the diagram, whether it's a sleeve or a bypass, and what's obvious is that you've got a smaller stomach, and the simple initial view would be, well, the smaller stomach is the main factor in weight loss. And we surgeons used to think this as well, but it's been shown, no, that's not the case, is that the smaller stomach is a factor early on in weight loss, And the smaller stomach is never really gone for most patients. The people have a smaller food capacity, but the more important factor is that the operations, the sleeve and the gastric bypass, also the duodenal switch, which I'm not going to say a bunch about, these effective operations reduce the hunger level so that the patient doesn't want as much food at the same time that they can't hold as much food. And what we're going to focus on as we focus on healthy metabolism is helping the surgery get back to that point where a person has minimal hunger and a good energy level. That's what I mean by healthy metabolism, and that's a very realistic expectation with surgery that's anatomically intact. It does not require reworking the surgery surgically to get back to a healthy metabolism with a smaller appetite. Now you may be skeptical. The proof of this concept is the band itself. We know now that the band fails in 80 to 90+% of patients over a period of years. People regain hunger, and even though they can't hold very much food, they still have hunger, and they begin, sensible people, begin to eat around the band because that's what their body is pushing them to do. And this is an expectation now with our current knowledge because the metabolism has not been corrected by the band. And so this is just an example of when you do a purely restrictive procedure, the failure rate is very high over time versus a metabolic procedure, which is the sleeve, the gastric bypass, the duodenal switch. These things will give lasting metabolic correction if they are handled correctly. That's where the 4 supporting pillars are going to come in for the central surgical pillar. If the testing comes back with normal surgical anatomy, whether we're talking about the sleeve, the gastric bypass, the duodenal switch, then what the surgeon is going to say to the patient is there's not really a surgical option at this time to help you get your weight back under control and to help you get your metabolism back under control. And this is a good news, bad news situation. Hopefully, nobody comes into the surgeon's office just wanting more surgery. Now, most people will trade the cost, the pain, the risk of surgery for getting their metabolism under control. But yet it's good news to know that the surgery is not broken and it should be able to help the person with their metabolic health for many years to come. And yet the bad news is that there's not anything immediate and sudden and game-changing that the surgeon and the bariatric team are going to have to help get this metabolism under better control, and it's going to be lots and lots of work. This is where the other 4 pillars of the metabolism are going to come back into play. The patient and the bariatric team do still have lots of options about how they can work together to get the metabolism back on track. Obviously, on some occasions, the testing comes back and shows somehow that the surgical anatomy is broken and that revision surgery absolutely is appropriate. And the surgeon is going to have that conversation with the patient at that time. For the sleeve, the most common causes for needing reoperation are reflux, which means that acid and digestive juices are washing back up into the esophagus, or that the sleeve is expanded or maybe wasn't created in a perfectly healthy way to begin with. For the gastric bypass, the most common reasons for needing revision are going to be that the gastric pouch is too large, that there may be some partial blockage, or that there's an abnormal connection between the stomach sections that's called a gastrogastric fistula. And as I said, if one of these findings is present on the testing, then the surgeon is going to talk to you about fixing that bariatric operation, kind of whether or not that has a positive impact on your weight and your metabolism, although quite often it does have a positive impact along those lines. A different fairly common finding in folks who have had bariatric surgery is the presence of a hiatal hernia. Now, hiatal hernia is a situation where there's normal anatomy. There's the esophagus, joins with the stomach, and of course bariatric surgery, this is a little gastric bypass stomach or it's a sleeve stomach, but at the place where these join, there's a ring of muscle that's supposed to be a support structure that stabilizes these things in place, doesn't allow excess movement. And if that muscle is loosened, that's a hiatal hernia. It allows excess movement, which can be a problem for the function of your gastric bypass or your sleeve or your duodenal switch, and it can cause reflux. And quite often the hiatal hernia should be repaired. It can be the case that repair of a hiatal hernia may improve the metabolic situation and may improve the weight control, but that's a little bit on a case-by-case basis, and I should leave that to the discussion of the surgeon and the patient individually. Now, even if the testing shows that there's something that's surgically correctable or that surgery is needed with reference to the previous bariatric operation, I still strongly believe that all of the supporting pillars should be working as well as they can so that the patient achieves the best results and the results that last for the longest years for the rest of their life. So those parts of the discussion should be part of what the bariatric team undertakes, ideally before or at least in parallel with the surgical planning process. Now, in a few cases, even when the surgery is not broken, even when the surgical anatomy is intact, the patient and the bariatric team will go on and they'll employ the other 4 supporting pillars as well as they can, and they may find that their metabolism still is not fully under control. That may be with reference to weight, it may be with reference to other disease conditions, it may be with reference to still feeling out of control with their appetite, even after all the supporting pillars that I'm going to discuss have been optimized. And in these few cases, what I say to patients is that, okay, your operation, whether it be the sleeve, the gastric bypass, in rare cases the duodenal switch, your bariatric procedure didn't exactly hit the target of your metabolic imbalance, and perhaps one of our other more intense operations may be employed. To have that discussion is beyond the scope of this video, and exactly what circumstances would be used, exactly what more intense operations would be employed, but just suffice it to say that in just a few cases, after the supporting pillars have been fully employed, it could be appropriate still to talk about revising a surgery that's not truly broken. As we move forward in our discussion, let's assume that you and your bariatric team have clarity about the surgical pillar, whether it's going to need revision or it's not. And now in this video, and hopefully in your clinic visits, we're going to spend a lot of time working on these 4 supporting pillars, because these pillars are a big part of getting lifetime healthy metabolism. The first of these supporting pillars that we're going to discuss is the food plan. And people think of food quite often when they think about weight loss and they think about metabolic health. The term food plan is very carefully chosen to be something different than diet. Diet usually is a temporary medical intervention. The food plan is meant to imply or convey the idea of something that's sustainable, something that you can do in the long run in your own life. We also don't discuss food as something that's evil or bad. Food is healthy. Food is important from a psychological, a cultural, a social perspective, and it's valid to enjoy food. So we're going to talk about foods that you can enjoy and that you can have a normal social life with this plan. Now, it's important to realize that food is hormonally active inside the body. Food isn't just calories. What you eat is going to have a big impact on your energy level and your hunger over the next several hours after you eat it. And so having a healthy food plan means that you're choosing foods that give you an excellent level of energy and an excellent level of satisfaction, and staying away from foods that give you hunger right away and make you feel drained or fatigued. For the most part, the foods that lead to better energy and better satisfaction are low carb and low chemical. Low carb foods means less sugar, whether we're talking about natural sugar or artificial sugar. I'm including fruits in the less sugar plan, which I'll come back to in a second. And also less starchy foods. Starchy foods include potatoes, rice, pasta, breads, corn, and other kind of white vegetables like peas along these lines that have a lot of calories without protein content. The low chemical part of this concept may not be as obvious to many people. I think most folks understand that preservatives in food can be disrupting for the metabolism, but we're learning more and more that artificial sweeteners can also be a problem with metabolic disruption. And it's too much to go into the science of that here now, but suffice it to say that it's been shown that pretty much all the artificial sweeteners, including the modern healthy ones, do lead to less energy and more hunger. So our advice to you is going to be to try to minimize the whole sweet flavor in your food plan. And so on the subject of chemicals, when you're shopping at the store, you want to turn the package over, you want to look at the list of ingredients, and if you're seeing ingredients on that label that look like they come from chemistry class, you should put that item back on the shelf. And I want to be practical with people when we talk about the chemicals that are the artificial sweeteners. Everybody can have a little bit of a sweet flavor as a treat, but I want you to recognize that whether it's a little bit of berries or whether it's a little bit of Splenda or stevia or what have you, that's working overall against your metabolic health, and it's something that's a treat. Now, what about fruit? Fruit is very widely sold as something that's healthy and even necessary for a healthy diet. And so one thing I'm assuming for my bariatric patients is that you are taking some bariatric vitamins and getting those vitamins. And I will also admit that for many people who have not had a history of obesity, who have not had a history of metabolic imbalance, that fruit could be a healthy choice for many of those folks. But our experience is that when folks have had this excess weight, when they've had the abnormal metabolic balance over time, that taking in fruits after your bariatric surgery most often tends to push the body back out of balance. So we have a very high level of concern and caution about fruits as a regular part of the food plan, just a treat. At the same time you're making healthy food choices, the bariatric food plan means that you should not drink at the same time that you eat. And I'm just talking about hydration. Now, of course, we care a lot about hydration from the very beginning, and we want you to hydrate with some non-calorie, non-artificial sweetener fluids on a regular basis, but we'd like you to do most of your hydration immediately before you eat, or in the long term before you eat. And once you begin eating and pick up the fork, we want you to push the glass away so that you don't use the water to turn your food into soup. The problem with soupy foods is that they're going to pass very quickly out of your stomach down to the intestine where they're absorbed. And so you've lost the ability for that food, let's say chicken nuggets, you've lost the ability for it to sit in your little stomach in a healthy way for an hour or two and give you a lasting sense of satisfaction. Also, by pushing that food or flushing that food down into your small intestine, you increase the rate of absorption of the food, and that's going to make it a little bit harder for your body to handle those nutrients from a metabolic perspective without getting out of balance. So bottom line, what we want to do is hydrate, hydrate, hydrate right up until you eat. And like I said, as soon as you pick up the fork, I want you to push the glass away and then to not drink again until like an hour after you eat. And this separation of hydration from food intake actually turns out to be the second most important factor to help people maintain a healthy balance over many years. Maybe you're curious about the most important factor that's coming in a few minutes. If you drink alcohol, that is part of your food plan. And if you're watching this video because your weight is rising and your metabolism feels out of control, unfortunately, I'm going to advise you to stop drinking alcohol completely. That may sound a little bit harsh, but here's the deal. Alcohol itself has a lot of calories. An ounce per ounce red wine has a lot more calories than regular Coke, believe it or not. Second thing is that when you have a little bit of alcohol effect, a little bit of a buzz, you don't make decisions as well, and you're going to go to a little bit more snacking and not stopping eating when you feel full. Also, drinking alcohol with your food is a different way of turning your food into soup with the problems that I just now discussed. And it's not just an idea that alcohol can be a problem, but alcohol is very strongly correlated with weight regain, especially when you drink on a regular basis. Can you have a little bit of wine with friends from time to time? Yes, you can. But again, if you're watching this because you're having trouble with your metabolism and your weight, alcohol could be a key part of the problem. One last cautionary note about alcohol is that folks that have had a bariatric operation seem to have a slight increase in the percentage of alcohol addiction, that's alcoholism, and so that would be a separate additional concern that could lead to excess weight and metabolic imbalance as a cautionary note. My last special subject on the food plan has to do with protein drinks. Many bariatric programs and many bariatric patients think of protein drinks as a key part of the overall food plan. And I think that protein drinks do have a place for certain parts of the bariatric surgery process. And I don't think that protein drinks are evil, but I am very cautious about using protein drinks on a regular basis going forward because I think for many patients, protein drinks can be metabolically disruptive instead of metabolic health producing. Why is this? There's a couple things. First of all, protein drinks are liquid calories. So once again, we have this problem of food being like soup. It flows through the stomach pouch very quickly, enters the small intestine very quickly, is absorbed very quickly, and all those things are disadvantages versus solid healthy food. I think also protein drinks don't have a natural flavor, and there's something about the satisfaction of natural flavor that's useful for people to have, again, this good sense of satisfaction and this good sense of energy. Thirdly, protein drinks, they have chemicals in them. They have preservatives and they have artificial sweeteners. And the chemicals can have a direct negative effect on the metabolism and again, leading to earlier hunger and lower energy. And so protein drinks very often come with the idea that somehow more protein equals more health. My understanding, and what I think we're seeing in the research these days, is that people who have had a bariatric operation that's functioning properly have a normal hunger level. And a normal hunger level means that they feel hungry when they need nutrition. And I think it's also true when you have a normally functioning bariatric operation that if you don't feel hungry, then you can trust that sensation that you don't need any nutrition at that time. Now, as I'm going to discuss in a couple of minutes, I do think it's important to be checking in with your bariatric team regularly and to get blood work done. That's mainly in the subject of vitamins, but it fits in with this conversation because I think if you have a normal nutrition level on your labs, you can be reassured that you don't need protein drinks. They can be okay if you're running out of the house in the morning and you're hungry, and if you're having a protein drink, it's going to stop you from picking up the blueberry muffin at Starbucks. Okay, that's perfectly reasonable. But in my opinion, to drink protein drinks because you think they help you somehow is probably counterproductive, and I think that natural healthy food is much more useful for your metabolic health. Now, I know we can be looking at some difficult habit change here. It can be pretty tough to let go of the sweet flavor, or the idea of washing down your food, or the occasional alcohol with friends, or to relax after work, or what have you. And I just want to reassure you, these are the kind of things that you can work into over the course of days and weeks. The first half of the day is the most important time frame to be really good. And this is because if you eat sugars in the beginning of the day, or whenever you eat sugars, it's going to cause your blood sugar to spike up, and then your blood sugar is going to crash down. And when your blood sugar crashes down, which comes naturally from eating sugar, what are you going to need? You're going to need more sugar. And that's a true physical sensation that is darn hard to beat. And then so you're going to have some sugar, and your sugar is going to go up and then down. And I call this the sugar coaster. And obviously this is a ride that you'd rather not be on. So if you really feel like you need a little bit of a treat somewhere in the day, it's best to push that until late in the day. Now, of course, I'm going to be a little bit tough on you, and I'm going to say, okay, let's have a full day without sweets at any point, or without drinking with your fluids. We'll talk about alcohol in a second. Let's say you go without sweets all day long. Well, I'm going to say, great, that was Monday. Let's try to get Tuesday, and let's try to get Wednesday. And the further into every week you can go with less sweets or without sweets, without the treat, then the better your metabolism is going to be. And then you get a full week. Let's go for a month, etc., etc. Alcohol is a different subject. It's a tricky one. And if you are someone who has an alcohol addiction, I think it's necessary to go cold turkey, fully off the alcohol. For some people, even that's very difficult, and you may need the help of a medical professional, and the Bariatric team can help you in that regard. Now, there's a lot more that can be said about the healthy food plan, and in fact, I've got another video on my YouTube channel all about the healthy food plan and healthy eating. But for now, we're going to move into the second supporting pillar for healthy metabolism, and that's the vitamin levels. Now, we can all understand that if you have a low vitamin level, that it's going to lead to an increased sense of hunger, because the body's going to feel as if it's missing something. Even the body doesn't know what it's missing, it's going to need something, and so there's going to be more craving. And it's also going to have a lower sense of energy and a lower sense of actually burning calories. Having a healthy metabolism is not just about less hunger, but also about more metabolism. And vitamins are going to be a big part of that. Now, even people who have never had bariatric surgery can have vitamin deficiencies because of our industrial food process, our industrial metabolism, but folks that have had a bariatric operation are a bit more at risk because there are some micronutrients that are not fully absorbed. And the different operations have different details. I'm not going to go into it here, but suffice it to say that the first key to having a full complement of normal vitamin levels in your body is to take bariatric specialty vitamins on a regular basis. There are several companies, which I'm not going to name here, that make bariatric vitamins for the marketplace. Your bariatric team can tell you what vitamins they recommend. Here in 2019, patch vitamins, which go on the skin, look like a nice idea because they don't involve taking pills, but patch vitamins have not been shown to have good, reliable absorption of all the vitamins and nutrients that bariatric patients need. Furthermore, there's biological variability from patient to patient. Some people need more vitamins, some people need less, some people need different vitamins, and so the second thing is to remain engaged with your bariatric team regularly in the long run so that vitamin levels can be checked through blood work. Again, it's not enough just to take the vitamins on a regular basis, but we have to check the results and potentially tune up or modify the plan going forward to have the best vitamin levels. And just in closing, having the best vitamin levels is what gives you the best sense of energy and the lowest sense of hunger. Now, I'm sure that ever since I teased you a few minutes ago by telling you that separating your hydration and your food is the second most important strategy for long-term metabolic health, you've been wondering, okay, what's the first most important strategy? And the first most important strategy over years and decades is actually regular long-term exercise. And we know that just by having this excess weight and the problems with the knees and the feet and the back and breathing, etc., that many people listening to this video can't do regular intense exercise. I know that's a fact, and we're going to talk about how we handle that in a minute. But first of all, the goal of regular healthy exercise is to exercise at least 5 days a week and to exercise for at least 30 minutes each time. Furthermore, I would say to you that the type of exercise is also kind of important. Now, I love any kind of exercise for people to do it regularly, but it seems that the exercise should include some strengthening exercise, or perhaps even emphasize the strengthening exercise. This is still up in the air. The idea with strengthening is that having more muscle mass means burning more calories. Muscle tissue is an energetically demanding type of tissue in comparison to bone and skin and those types of tissues. So having another kilo of muscle means burning substantially more calories on a 24-hour basis. So building muscle helps you burn calories even when you're not actually exercising. And the largest muscles in the body are the thighs, the buttocks, the core, and so doing exercises that are in the family of squats and kind of heavy lifting are the kinds of things that seem to be the most effective for long-term weight control. Now, what if you are one of these folks that has severe limitations with their exercise, whether it's cardiac, whether it's pulmonary, whether it's joint and musculoskeletal? These are realities, and I would say to you that we've got professional teams that can work with you to help you do the most exercise that you can practically do. And at least having efforts in that regard and investing the time, these are going to be important factors for your long-term weight control. Some of you can't exercise at all because of very serious medical conditions, and I recognize that as well. I just want to be practical and realistic. If you actually literally cannot exercise, your results are not going to be as good, and that means that you already have a damaged metabolism that can't ever return to full health. So that's regrettable. Let's do everything that we can to get you in some physical activity and work around your challenges as best as possible. Special note on athletic trainers. Some of the patients that have the best success are the ones that invest the time and the energy and the money in having a personal trainer, and that can be fantastic because to have someone there with you who is working with you on the exercise as a motivator, as a teacher, can be just a tremendous resource. Cautionary note that many trainers want to also promote a certain set of supplements or vitamins or food products, amino acids, etc. And when I'm talking to my patients about personal trainers, I ask them to make a deal with the trainer at the beginning that yes, the trainer can work on all the physical aspects that they want to with you, but we ask for the physical trainers to stay out of the nutrition supplement aspect of things because quite often these are chemicals, and quite often the concepts that they have are at odds with what we understand works best for bariatric patients and long-term healthy metabolism. The newest of the tools that are often used to help patients with their long-term metabolic health are the metabolic medications. Gradually over the past couple of decades, the metabolic medications have been getting better and better. These fall into several categories. Some of them are actual appetite suppressants, some of them are metabolism boosters, and some of them treat medical conditions like diabetes that often go with the excess weight and at the same time have a beneficial weight loss effect. Regardless, we've moved away from the old concept that people needed to be treated either with surgery or medications, and we've come to understand that medications can be used with the surgery as a booster for the surgery if the surgery alone is not impactful enough, and that can be put to work. The medicines can be put to work in the first 6 months after the operation, or 6 years after the operation, or really at any time. And very often medications are actually used in combination together. The management of the medications is a fairly medically intensive process, and so in bariatric teams, the application and implementation of medications is most often done by an internal medicine doctor, a bariatrician, or a physician assistant or a nurse practitioner. The surgeons may prescribe these things, but it's uncommon for surgeons to be the primary prescribers because they are more often in the operating room, and management of the medications will require, at least early on, a series of visits spaced close together so that the meds can be assessed and adjusted to get the most benefit. Surprisingly, sometimes I hear patients say to me, well, I've had surgery, I should not need medicines. And I understand that, and I wish that was true in every single case, but it's the fact that the surgery isn't always completely therapeutic. It doesn't always get the patient completely to where they need to be or want to be. And we as surgeons have become much more open-minded about this. I encourage patients to be more open-minded about it as well, and to understand that we're dealing once again with a lifetime metabolic process, and it's not a surprise that additional intervention or work is required at some point down the road. As we wind this up, I hope I'm leaving you with the idea that managing and optimizing your metabolism is going to be a lot of work, but it's work that can pay off. Your bariatric team does not have all the answers today. But science is improving fairly quickly in this area, and our concept is that as long as you stick with us and keep doing the work in spite of the occasional frustration, that we'll stick with you. And together, I'm optimistic we can help you be more and more healthy. Good luck, and let's get to work.